Well, welcome back, everyone. We want to know how you think the sessions are going so far. We've heard from some of you that you were loving them so far. You can let us know by adding questions or comments in each of the sessions Q&A section in the Whova app. I wanted to welcome our next panel, Building Support Systems for Early Parenting, Policy and Payment Strategies. It's my pleasure now to introduce Maggie Clark, the panel moderator for this session. Maggie is a senior state health policy analyst at the Georgetown University McCourt School of Public Policy's Center for Children and Families. She leads work on improving Medicaid coverage for pregnant and postpartum people and leveraging Medicaid to support the healthy development of young children. Before joining Georgetown University, she was an award-winning health journalist in Florida, covering all aspects of Florida's health delivery system. She's also held various research positions at the Pew Charitable Trusts in Washington, D.C. Maggie, we are very excited to have you. Welcome to you and our esteemed panel. Over to you.
Thank you so much, Joy. It is just such a pleasure to be here with all of you and for the warm welcome already that we've received today. I hope I speak for everyone. I've already learned so much today from Dr. Bruce Perry, Rachel Pryor, Jim and Andrea, Dr. Nonax, and I'm so privileged now to get to moderate this panel of experts to turn towards the policy conversation today. So how do we get to some of the policy changes, use policy levers to build the support systems and foundations for young families and support moms, parents, babies together? So as Joy mentioned, I'm Maggie Clark. I'm at the Georgetown University Center for Children and Families, based at the McCourt School of Public Policy at Georgetown University in Washington, D.C. We're a nonpartisan policy and research center with a mission to support access to high quality, comprehensive, and affordable health coverage for all of America's children and families. And we work primarily on Medicaid and CHIP coverage policy, where I lead our work on maternal health coverage policy and work with amazing colleagues in early childhood, child health policy. So I just kind of wanted to take a moment to reflect too on some of the things we heard earlier, as Rachel Pryor from Department of Health and Human Services and said, you know, at the opening of today's meeting, we've really seen great strides recently as more than half the states have lengthened the Medicaid postpartum coverage period, which we know will be hugely beneficial as Medicaid finances nearly half of all births in the country and more than half the births to women of color in particular. And so we're hopeful about the opportunity to rethink in that postpartum year how that works for mothers and infants together, and some of the changes that can be made to support maternal and infant health, early childhood health, and mental health together. So support, as we heard from Dr. Perry, in these early months for parents and babies really holds such great opportunity. We heard from Dr. Nonax on the research. And we know that the consequences of particularly untreated maternal mental health conditions can really get in the way of some of these healthy relational developments. And so that calls on people across disciplines to think about all the system changes together that we need to support the healthy development of moms and children together in that early period, in those early months and years. And so that brings me to the panel today. We're going to talk about building support systems for early parenting, policy and payment strategies, and doing the hard work of changing systems that Dr. Perry described. So our experts today will highlight some practical policy levers that can be used to advance support for early parenting, some early interventions for those with perinatal mental health conditions in the OB practice, primary care, pediatric care, and investing more in prevention. So now I'm going to start with some introductions for our speakers. I think we'll bring them onto the screen. I'll turn to each of them for a short introduction, and then we'll get into our panel discussion today. So first, I would invite Dr. David Willis to say hello and introduce himself.
Hi, everybody. Yes, I'm delighted to be here. Dr. David Willis. I'm a pediatrician, developmental pediatrician. I'm a senior fellow at the Center for the Study of Social Policy, working to advance early relational health at that intersection of child health transformation and resilience communities, partnering with families, and the social justice commitment that's critical to this good work. I'm fortunate to be the co-chair of the National Academy of Sciences Forum on Children's Wellbeing, previous inaugural executive director of the Perigee Fund, spent 7 years as the division director of home visiting and early childhood systems at Maternal Child Health Bureau during the Obama administration. And before that, a clinician in Oregon, working to support families day by day in their strong relational experiences, their longing and desires for the well-being of their children. That's what's galvanized my work. Thanks.
Thanks, Dr. Willis. And next we'll give Dr. Cynthia Osborne a chance to introduce herself.
Well, thank you, Maggie, and thanks so much to all who are putting this great event on, and I'm so thrilled to be a part of it. I'm Cynthia Osborne. I'm a professor of early childhood education and policy at Vanderbilt University, and I also have the privilege of directing the Prenatal to 3 Policy Impact Center. And at the Policy Impact Center, all of our work builds on all of the science of the developing child that clearly identifies what the conditions are that children need to thrive. And what we try to do is identify the state level policies that help to create those conditions. So again, thank you so much for allowing me to be part of this.
Yep. And next we'll hear from Megan Schmalzer.
Thanks, Maggie. It's so great to be with you and everyone here today. So I'm Megan. I'm coming to you from Michigan, and I am on the infant and early childhood mental health team within the Policy Center within 0 to 3. And I like to say that I started as an infant mental health consultant, and then I was an infant mental health home-based clinician, and then found my way to the state of Michigan as the infant early childhood mental health coordinator and really supported our state's mental health consultation team. And I bring those voices and families and babies and stories with me into this policy world. And so in my role, I provide a lot of technical assistance to states and grantees around all things infant early childhood mental health. When states say, oh, this really is the most important thing that we can put our money into. Now what? Like, what does that even look like? So I get to work with a lot of wonderful people nationally and help build their systems. And really, I'm a proponent of the reflective practice and building equity right along with these relationships that we do. So it's great to be with you.
Thanks, Megan. And finally, Alex Briscoe from California.
Everybody, my name is Alex Briscoe. I'm the principal of the California Children's Trust. I am a Medicaid geek, a broke down bureaucrat, and a recovering therapist. I'm very much focused on the design and construction of benefit design and construction in Medi-Cal managed care, in waiver design and construction, and reimagining mental health as a support for healthy development, not a response to pathology. It's great to be here. Thanks.
Well, thank you all so much. I'm going to start with a question just to Dr. Willis, but at this point, I mean, I think we're open for the group to just jump in and talk about everything that we're going to dive into. So, Dr. Willis, I would just ask if you can kind of reflect on what we heard earlier from Dr. Bruce Perry, you know, and you mentioned in your introduction your work in early relational health. And kind of what does that mean? What are we talking about when we think about this this period? And two, how do you think about that in the context of maternal mental health?
Yeah, thanks so much, Maggie. And like all of us, I'm sure we were inspired by Bruce Perry. And I met Bruce 25 years ago, and he and I had many conversations then about the criticalness of the context of human development that's relational. And he really championed the sense of relational context matters. And he's taken it ever further to really talk about, you know, what have we known evolutionarily and culturally for long times about the relational networks of support that assure well-being. And I've been on that kind of thinking and awareness journey my whole career as a pediatrician, looking at as originally seeing the challenges of young children, often where not enough relational experiences and supports. And then now we're staring at struggles with isolation, the sense of people disconnected, the sense of young children being lonely, and then the emerging mental health crisis. And all of those kind of calls are calling for the criticalness of being connected and being relational. Now, I'm an early childhood person, meaning I care about the building of well-being. And as Bruce was alluding to, that has a lot to do with brain development. and leaning through the experience of the 90s, the 2000s and onward about the critical experiences of building brains. It's all relational. And we would say that relational outcomes, all outcomes rather, come from the relational experiences. Health, education, well-being and early literacy, social emotional well-being, engagement in communities, participation are all relational outcomes. So it points to those earliest experiences. And maternal well-being, family well-being, the supports of women and families and networks around the birth of a baby really matter. That's how we came to really activate and elevate this concept of early relational health. And we've taken it a distance. Many of you may have seen our new website called Nurture Connection, which has called out this movement building agenda to focus on positive, strong, and nurturing early relationships in healthy and resilient communities to build a connected world. But under that is this emerging science of early relational health. It's really not a new concept. It's come out of decades of research in the fields of infant mental health, child development, neurodevelopment, builds on what Bruce was talking about that neurosequential sense of prenatal experiences, postnatal experiences, those critical early months. Those relational experiences matter. And as we've called out in the science about, human development occurs in the environment of relationships, we've tried to activate, and what are those quality relationships? What's the research? What's the awareness? What's the knowledge? And once one moves into view human development through a relational lens, you can't go back. Then you start seeing forces that disrupt those natural processes, do not allow the allo-parenting activities of 4-to-1 supports around a new baby and a mother, culturally, that Bruce was alluding to, that I think should be driving our policy space. So what's early relational health? We focus on the importance of early relationships and experiences in the healthy development across a child's lifetime. In specific, it's that state of emotional well-being that grows by those connections of babies and caregivers and supported by strong nurturing relationships. We know that it's dyadic, meaning relational health is every bit as critically important and meaningful to the caregivers, to mothers, fathers, and those around them as it is to the well-being of the baby. It's not simply utilitarian for the baby's development. It really is the well-being of the family and the caregiver themselves. And there's some amazing research that's starting to point in that way. There's a lot more we could talk about. It has huge policy implications. It is a movement generating opportunity, a partnership with many, as is with 2020 Moms, calling out maternal well-being, maternal mental health as being key, and surrounding the social supports and networks that are critical for that to happen. So I'll stop here. Thanks.
Thank you. I'm going to ask one more kind of foundational question, then we're going to get right into the policy because you took us there right away, Dr. Willis. So to Megan, especially from your perspective at 0 to 3, you alluded to infant and early childhood mental health. And just to give people a backgrounding, is that the same as early relational health? How do those things kind of interact? And then we'll get into the policy conversation next.
Yes, absolutely. So we like to think of infant and early childhood mental health, or infant mental health for short, in a couple different ways. So on an individual level, infant early childhood mental health is really this developing capacity of an infant and young child to form close, secure relationships, as David was talking about, experience and manage a range of emotions, and then be able to explore the environment and learn, all deeply held within the context of the family, of the culture, and of the community. We really look at this inclusive of the perinatal period, so prenatal to 5. And then on a systems level, infant early childhood mental health also refers to this multidisciplinary field that is kind of the sweet spot between the early childhood world and the mental health world. And really, we refer to this as a continuum of services and supports that range from promotion, prevention, assessment, diagnosis, treatment. And really, regardless of where you are entering on this continuum, it's all about supporting the emotional and social competence of the little one and the adult who cares for them, And because of this conceptualization that infant early childhood mental health includes the perinatal stage of life, of course, with prenatal birth and in the newborn period, as well as infancy through childhood, we very much recognize that the mental health of the baby is inextricably tied to the mental health status of the mom or dad or primary caregiver who cares for them. So, for example, if you have a mom or a dad or childcare provider even who's clinically depressed, that will absolutely impact how they are able to interact and recognize and meet the needs of their baby, which in turns impacts the baby's attachment to their caregiver and ultimately their own mental health. So therefore, if you care about infant and early childhood mental health, you inherently must care for and worry about the maternal mental health, and vice versa, because this really is a reciprocal relationship. And also to note, we at 0 to 3 are in a process of creating this document around infant early childhood mental health guiding principles that's hopefully going to be shared later this year with the field. And one example of these principles that we base our work on is really that the field of infant and early childhood mental health must reflect and advance socially just and equitable practices and policies that consider all families, expectant infants, young children, and their families, that honor the diversity of those who are served. And again, this is central to our work, and we can speak a little bit more about that later. But and now to your question about the terms of early relational health and infant early childhood mental health, I'm really glad that you brought this up, because the last thing we want to do is confuse anyone, much less those who are doing this really important and rewarding and difficult work with babies and families, or the policymakers who are making decisions around funding about that directly impact this field. And so that said, these terms are highly interrelated and overlapping, and they speak to the same priorities. Early relational health focusing on the health, as David said, of the relationships that are obviously central to infant early childhood mental health. Both of these speak to the critical importance and stability and nurturing early relationships that are really these essential pieces for future health and well-being. And I think, like many things, we know that different terms resonate with different audiences. And yet these core messages are the same around young children needing consistent nurturing relationships supported by healthy adults. So early relational health is used and resonates really well, it seems, with physical health care professionals. Infant mental health really is used by mental health providers, just as social emotional health is broadly resonates with those in the early care and education world. So a variety of supports and services advance infant mental health and early relational health, regardless of the differences between the terms. The key takeaway is the early nurturing these relationships contribute to resilience of building these little ones who are going to grow up and be students in K through 12 classrooms and eventually adults. So we're just glad people are talking about these concepts regardless of how they get here.
That was so helpful, Megan. Thank you. And now to Dr. Osborne, Cynthia, I think, your work is so much connecting all of these research to policy. What are some of the things that, the research tells us work to advance early relational health, infant early childhood mental health, kind of this whole field of study? And so I would love to hear from you kind of how you approach that work, and then maybe tell us about 2 or 3 policies that we should be thinking about that states and federal policymakers can be thinking about to promote healthy development in this time.
Great. Well, I'm happy to. So at the Policy Impact Center, like I said, what we try to do is to understand what are the most effective policies that help to create these conditions that both David and Megan and Dr. Perry were referring to, of how to make sure that our children are growing up in these nurturing, safe, stable, stimulating environments that have long-term consequences for their health and well-being. And so we reviewed dozens of state level policies to understand which ones have the strongest evidence of effectiveness. And we have an annual roadmap that we release so that folks across the states can see how states are doing toward implementing these effective policies. And I know that we can put that in the chat for folks who aren't familiar with it. But I wanted to, I'll talk about a few policies, but some of the big takeaways that we found, and this is, not anything that people don't already know, but I think it's important to say, is that there's no magic bullet. That in order to create these conditions, it requires a combination of broad-based economic and family supports, as well as targeted interventions. That for families, what our goal needs to be is to reduce the stressors that families are exposed to if they don't have access to healthcare, if they don't have access to stable income, or if they have food insecurity. We need to reduce those sorts of stressors. And we need to be able to identify the specific needs of a particular family and connect them with this sort of services that meet their needs specifically. And it's when states are doing this combination of kind of economic and family supports and targeted interventions that we see that families are going to be better able to thrive. And some examples that I think are what we know that's effective and that states are doing. So paid family leave policies are one of the most important policies that we can implement, specifically related to building early relational health and infant and early childhood mental health, maternal mental health, just family well-being in general. Not only are these policies good from an economic standpoint, they're pro-work policies, they increase the family's resources, but they also increase attachment and bonding and the mental health and physical health of the mother, as well as the child. And currently, there are 12 states that have adopted a paid family leave policy. It's being fully implemented in 8 states, and Oregon is going to roll out its program this year. We're expecting that Minnesota is going to sign off on the bottom line and implement it again, or be the next state to implement it this year, or adopt it rather. And so it's spreading, but this is something that we know could really benefit from federal intervention to be able to improve the lives of infants and toddlers and their parents. And so that falls into that broad-based economic and family support. But then we have some of our targeted interventions. And most of you are familiar with the early intervention program, or Part C. Every state calls it something different, whether it's early childhood intervention or what. But this is an important program for identifying any children who are experiencing developmental delays that are often at that age caused by kind of a lack of early relational health or issues regarding attachment or bonding that we know can lead to problems with both the infant and parents' mental well-being. And so those programs are an important tool for states to be able to access, for families to be able to access. But what we know in some states that more than over 10% of kids are accessing their early intervention programs, and in some states it's less than 3% of families. And so making it so that states are funding this, using Medicaid as exhaustively as possible, requiring families who can pay with private insurance to use those dollars first to free up other state dollars for more services. There are different ways that states are going about implementing that so that more families who need these services are able to access them. So there's just a couple of examples, just one more, because David, you mentioned how important it is that we think about the caregiver, not just the parent, but any caregiver. And so in some states are using their child care subsidy dollars to really focus on quality. And by quality, what they're focused on are those nurturing relationships between the caregiver and the child. And that's a crucial component of a system of care that really is prioritizing the health and well-being of the infants and toddlers and their parents.
Those are great examples. Thank you, Cynthia. And finally, I'll turn to you, Alex, because I think of most of us, you've really been in this work in California of retooling the state Medi-Cal, Medicaid in California's Medi-Cal, reorienting these systems to prioritize early relational health. So I know California and you've been a really important pioneer in this space, thinking about whole person care and kind of give us the context for the need that you're facing, the solutions that you've pursued in policy in California to kind of make real some of these issues in early relational health and support families.
Thanks, Maggie. Yeah, it's super practical, you all. I'm always so honored to be included on panels with these heroes of mine whose stuff I've read. But I just want to begin by saying, like, I'm very much like a safety net administrator guy. Like, if you're not paying for it, you're not doing it, kind of thing. So I can't also help but comment on the disconnect between the brilliance of folks who are talking, including Dr. Perry, and the rules of Medicaid. Like, the chasm between them, between the kind of consensus on the policy and advocacy and academic side and the practice of reimbursement, man, you almost couldn't create a bigger rift. And very directly, we did two very specific things I'd like to reference to people put their teeth around it. The first is we really focused on the definition of medical necessity in Medicaid. Medical necessity is the bar to entry. And at the heart of all of our challenges of reimbursing for the type of stuff everybody's talking about is diagnosis-driven identified patient reimbursement. Like, that's the ball and chain of Medicaid, is you got to diagnose someone and you have to assign a benefit to a beneficiary, which basically creates a fundamental barrier to reimbursing the type of models that we're all talking about, where you treat the mama and baby together. So we went right at that in benefit design and waiver construction and rewrote the definition of medical necessity, removing diagnosis as a prerequisite for care. So that means reactivating Z65.9, Z78.1. These are Z codes associated with diagnostic criteria that have nothing to do with diagnosis. One is actually specifically in the absence of diagnosis, and another is triggered by an experience of discrimination or housing instability, food insecurity, or the other adverse child experiences. So crosswalking the expertise you just heard into actual codes is what we did first on medical necessity in the creation of this thing called the new family therapy benefit. And then in the second, through the creation of the dyadic benefit that went live January 1. I heard a couple of weeks ago that New York adopted it. And that sounds really fancy, you guys, but I want to say it's not very fancy. We wrote a paper with this amazing psychologist, Dr. Kate Margolis, who is our muse. And the title of the paper is Babies Don't Go to the Doctors by Themselves. And you don't even need to read the thing, because that's, you get it already, right? Like, low-income people interact with the healthcare system, but most frequently when they take their babies to the doctor. And what we don't say enough of is how amazing poor people are at showing up for their kids. They have a lower no-show rate than privileged people for their well-child visit, which is like an extraordinary fact that we should all be talking about every day. But because of that diagnosis-driven identified patient reimbursement structure, we couldn't do stuff for them. So kids 0 to 5 have the lowest rate of mental health utilization in all Medicaid programs, because what pediatrician is going to diagnose a kid who can't walk or talk, right? And you can't support mama even though she's in the room. So Kate is a Healthy Steps guru, and I want to acknowledge the expertise of the 0 to 3 community, which we relied on. Thank you so much for Hill and Jen Tracy and so many others who really guided us. Megan, thank you. And basically all I did was walk around with Kate and her clinicians for a few months and said, how would we code that? And we basically figured out how to code Healthy Steps. And that's literally what the dyadic benefit is. Like, if you crosswalk the CPT codes that we created, they fit right into tier 1, 2, and 3. We did a demonstration for 1 year with 2 health plans. They saw all kind of bread getting buttered. Higher maternal screening rates, better well-child visit adherence, beyond just the direct services, which are the real gold. Plans saw lots of good benefits. The state adopted it, 800 million, went live January 1. Basically, it's going to be the biggest and best chance for us to expand access to behavioral health in the history of Medicaid, because mama's already there. She's in the room, or he, a caregiver, is in the room. And we developed a series of codes that have nothing to do with pathology. So let me pause. I want to say one more thing, actually. If you're trying to look at what we've done, I think look at medical necessity, look at benefit design, and then consider expanded provider classes, doulas, CHWs, peers, wellness coaches. I think those are the three essential elements to Medicaid reimbursement practice to further the work of the experts you've heard from today.
Can I
Anybody
leave
who
for a
wants to jump
second?
in, yes, please.
Yeah, Alex, thank you, and Healthy Steps, thank you, and opening that door for a transformational opportunity from a relational health standpoint. It's a breakthrough, a critical breakthrough. And as you were alluding to, Alex, there's a growing relational health workforce to bring in to the medical home. One might consider that the high-performing medical home-like concepts of Healthy Start, Dulce, community health worker connections, and then all other opportunities for team-based care opportunities to touch families' lives. The other element I want to add, it's not all about the health system alone. Certainly, that's a critical touch point, but we're trying to activate communities and informal supports and knowledge that is held by communities of parents and providers and networks of people that are all concerned about their children's and their children's well-being, which is around maternal well-being and next generation partnerships. So there are increasing communities that are thinking in that way of galvanizing together, building off of models like the Harlem Children's Zone, like now the baby bundle work in Bridgeport, like the work that's going on in the Carolinas and others that are really trying to harness formal and informal supports around every pregnancy and every mom, not the least of which is the doula movement that we can talk about a little bit later. So thanks, Alex, for your leadership there.
Does anybody else want to respond? You're speaking my Medicaid nerd language as well, Alex, talking about, right, individual eligibility and trying to make a, more of a dyadic approach and kind of reorient Medicaid to think in the way that we think now. Does anybody else want to respond to that, or we can?
I'll just quickly say, Alex, you are the perfect translator, because I feel like often that's what we need, is that translator between theory and practice. And, that's, I think, what all of us are trying to do in different ways, and connecting these policies with family driven needs and babies, and connecting all the dots, and just recognizing the power of the community. And none of us we were never meant to be in this world alone. And I just think from the parallel process, from the infant mental health world, the connection that all of us in different systems work, the more we can keep our focus on families and babies, but work together in, in situations like this, that's how we're going to move forward.
And the only thing that I would add is that this is the type of creative thinking that states just really need to do. That what we're seeing is that there are often states that are putting investments toward policies, they're adopting various policies, and they are really strong, good policies. But when it comes to implementation, they're hitting these roadblocks, and it will take them years and years to figure out how to pay for this, or to use Medicaid to pay for things that, we know that Medicaid can, because some states are already doing it and so forth. And so any way that we can share among states how to reduce these barriers and make it so that these good intentions are put into practice is so important. So Alex, I appreciate what you're doing, and how we share that, I think, is just crucial.
One more theme that came up from Bruce was the comment he made about the brain treats the novelty as threatening. Change in this space is hard. And Alex, thank you for your courage and your vision, right? And your determination to really crack open a new way of doing things. And there are a lot of resistances at times. Change is hard. And I wonder if you can comment about that a little bit too, to this audience.
Yeah. And I feel like I just want to acknowledge, I feel like I'm sometimes taking credit for stuff or getting credit for things that I had nothing to do with. Like, very much this work is just trying to align the practice with the reimbursement. And it's like, it is nitty gritty. It's tough. You actually got to have worked in these systems. I didn't mention, but I led one of California's largest healthcare systems for public health systems for a long time. And I really feel like a lot of us are working on just trying to get the payments to pay for the things we knew we needed. And at the heart of that, I just want to highlight this really important point, and I'll drop it in the chat, is that the future of mental health looks more like a support group or a 12-step meeting than it does a psychotherapy session. And we hear so much about the provider shortage in mental health. And to me, I think, like, thank God. Like in California, 80% of kids on Medicaid are children of color, 82% of licensed clinicians are white. Like, and I don't mean to attack anybody. Like, us white people can help people of color for sure, but we must build a much more culturally congruent workforce. And it's starting to happen. In California, there are 4 new provider types in the last 18 months. Doulas, as others are doing, Go Team, CHWs, we were late to the party, peers, California, late to the party, and wellness coaches.
Yeah.
All 4 represent a chance for us to bring 10 to 15,000 people with relevant lived experience into the workforce, shifting the economic benefit of the Medicaid program towards the communities it was intended to serve. So I hope folks heard that third part of my kind of call to action, like, get it, criteria, stop pathologizing people, do it where they're at, pediatric primary care and schools. But third, rethink who does the work and who gets paid to do it.
Mhm.
It's going to be cheaper. And there's this incredible wisdom and intelligence. When we all face problems, we get together with other people who are facing problems and share stories. But we have really disconnected low-income people from their peers in ways that would build social capital. And I think Medicaid could be a strategy for that.
That takes us right to where I wanted to go, actually, which was to talk about these workforce expansions. Although, Megan, I saw you unmuted. So do you want to say something before we get there?
Just briefly, that was something I was hoping to get to at one point. Absolutely recognizing the lack of diversity of professionals of color within the clinical workspace. In 2021, 0 to 3 brought together and hosted a group of 44 infant early childhood mental health providers and professionals, and they formed this group called Infant Early Childhood Mental Health Clinical Workforce Diversity Collective. Just rolls off the tongue. So it's the Diversity Collective. But really the purpose of this collective was to begin a conversation and exploring issues related to diversity, equity, inclusion, and belonging within the clinical workforce, and finding ideas to really address them. And so this group was really based on the centrality of the parent-child caregiver relationship and the pervasive impact of racism and historical trauma on families of color. And so I'll drop, and I'm saying this because they just released a video all about this, and I'll drop it in the chat. So if folks are interested, they can take a peek at that.
Great. Yeah. Well, and I think that there's so much promise in workforce expansions, and we can talk about that. But I also think, Alex, to your point, it hits up against Medicaid barriers. Medicaid, pays healthcare provider, licensed providers for a specific service to a specific individual. I think private insurance, really kind of follows similar models. Can you all, so I guess that's 2 parts of a question. One is to look at, what are the movements? We talked about doula care and doulas for the perinatal stage, but also the postpartum stage and supporting even in home visits. And we're seeing that both in Medicaid and private insurance. You mentioned community health workers. Maybe for folks that aren't as familiar, can you talk about peer supports and wellness coaches, and kind of give us a sense of what does this workforce look like? And David, too, I think you call it the relational health workforce, which I really love that term. I've started to use it with folks. So yeah, I guess the question is to whoever wants to take it, can you kind of give a description of this workforce? And then we'll move into more the policy discussion of why and what challenges states are facing as they try to grow this, and things that we can do to make those policies work better.
I'm happy to start, and then others please lean in. Actually it was Charlie Bruner that started coining the term of relational health workforce. And he was calling together under his good leadership work, relational care coordinators, family developmental specialists of Healthy Steps, community health workers, home visitors of all ilks and kinds, then family coaches, promotores, doulas, family navigator. These are all center their effort in partnering with families. Now that opens the equity issue. It opens the cultural congruity of people that are trusted with other families in neighborhoods and communities that are part of what has to be this, the equity journey and the partnering and the trusted journey. We've had the privilege also of working with the doula networks deeply in terms of learning with them about the relational healthcare work they just do day by day, and realizing that it's, historically related, has been around for eons, a part of indigenous wisdom forever, still deep within many communities as a support network around pregnancy and delivery processes. We're discovering it, increasing at the policy level. But the power of those relational connections with families that doulas bring, narrative, trauma resiliency recovery, trusted partners, protecting against forces in delivery systems that make it difficult for feeling safe for mothers by having a buffering role that doulas can play. And then the community doula movement, which is actually partnering prenatally into the first year as, so I would say, home visitors. That network is really, increasingly recognized as important within the policy spheres. Now, the devil's in the details. Oregon was one of the first, there are others, but Oregon has been a state that I'm keenly aware of. It has a policy mandate now that every Medicaid mother has the availability through Medicaid support for doula care. At first, however, there wasn't sufficient reimbursement rates, like $300 for a delivery that could take hours of a doula's participation, and no workforce showed up. Then through advocacy work by the doula networks themselves and leadership within that network, they were able to actually move Medicaid dollar cost per encounter to $1,500 per delivery, which helps build then a workforce. But even still, there's not a sufficient workforce for the need. And then, so the devil in the detail of building a workforce into that relational health supports is really yet then an important strategy. Similarly, community health worker. Washington State has created a policy agenda now training community health workers into the medical home for advancing a relational health frame as well as supporting the mental health work. Even still, the number of people needed to build that into the medical homes is still a workforce strategy and also a challenge in front of us. But stay tuned as that work's moving forward. So I would say the relational health workforce is policy opens up as a critical opportunity, but the devil's in the detail of building that workforce and helping them be ever more relational and to know how to bear with reflective practice their experience of being with families with challenges, because that's not easy work. And so it brings to that importance of the support of the workforce in its developmental process.
Just add on the details. Everything David said is so right on as usual. The details that he's speaking are basically devolved to a couple of essential elements. Of first and most important is rates, as he just went through. If it doesn't pay a family sustaining wage, it doesn't matter. But then comes paneling, credentialing, and organizational protections. So if you have a rate that works, you still have to have get signed up to get paid, paneled. Who determines you are who you say you are, credential. And solo practitioners do not really exist in Medicaid. I mean, they do, but they never thrive. So in what organizational model will they work? So everything David said, plus those four considerations is how I would define the details.
Mm-hmm. I mean, I'll just speak for my own experience with that. That's absolutely right. And where, we see states really struggle, but are also, I point again to California, some of the work that's happening. I was just speaking to a group actually in Kansas that's trying to start thinking about how do we learn from frankly, the states that didn't do it right, where that they didn't talk to doulas before they set a rate and set a rate of 75. I mean, Oregon started at $75 for the entire span. Minnesota was $350, I think, and just said, please come and work for our clients. And people didn't do that. And so I think it speaks to, maybe Dr. Osborne, you can reflect on this, the idea about, you want to create a policy, but you also want to create a policy that works. And so kind of where are some of the break points and opportunities to get this right?
Yeah, I think that that's absolutely true, because the variation across states is so wide. This is where researchers could step in to do a better job and say, well, what is the threshold or the optimal rate that needs to happen in order to incentivize a workforce or to have a stable workforce? We're trying to do that more in childcare, but I think in the relational health workforce, we're going to have to do the same sort of thing, because these are folks who are doing incredibly difficult work and often not compensated at levels that are commensurate with what they're doing. I think of home visitors, and David, you've spoken for decades about the importance of really recognizing the work that they do, but they are relatively lower paid. And what I want to be careful of is that as we expand the workforce, we're all recognizing how important that is in meeting the needs of families and improving outcomes in the short and long term. But I think that we're at risk of having a lower paid workforce doing the work of serving a lot of families of color as well, which it just repeats the cycle that we have done for generations. And so I'm not suggesting that we're not moving, forward, which is important, but we do need to be really mindful of how we're doing this and respect and honor and compensate the workforce, train them, make sure that they're well trained, all of the things that we expect out of a professional workforce. But I worry that states are going to implement this. And as a policy leader in a state, if you fund something and then you see that no one shows up or it's not getting the benefits that were promised to you, the likelihood that you're going to continue to fund it goes down. And we don't want that situation to be in place. We know that these things will work if we do them well, and we have to do better at figuring out what that right target and right approach is.
Yep, and I see, Alex, you put in the chat, and thank you for doing this, that in California, they originally proposed $450 for a whole doula bundle with, multiple visits, presence at birth, multiple postpartum visits. And that was totally reworked. And thanks to some amazing leadership nationally by the National Health Law Program, Amy Chen, their Doula Medicaid project, tons of doulas and advocates in California. So if you want to say more about that, Alex would welcome that. No, okay, great.
Maggie, could I add in one thought, and that is it reflected to me what Bruce was talking about in terms of social movements and the criticalness of parent voice, mom voice, this moment in time, this symposium now, and all collectively being visible and clear to what has to be anew. Think about the work about Parent Nation, think about the work about Moms Rising, think about the maternal mortality, maternal well-being movement, holding these collectively and pushing and not compromising. Around right back to what Cynthia has been saying, and I've been hearing in other sectors, are we going to create a second-class citizen of the relational health workforce rather than primarily supporting livable wages of those dear people so that their children likewise do well? Because right in early care and education, so many of the caregivers likewise are struggling on the edge and thereby disenfranchising a support structure of building well-being relationally. So I think we have to be very mindful and activate the social movement element of this nurture connection criticalness of movement. That's really a part of this kind of transformation, and keep calling it out, not compromising, because I worry like the counter forces that make it difficult for change, the power dynamics and the movement of dollars is still a real challenge for us.
So I want to take us back a little bit more to maternal mental health and just kind of mental health policy looking forward. We've got just a few minutes left, and I think somebody said it earlier today, but there is there are several packages of federal legislation kind of on mental health. Largely, we're hearing a lot about this crises on all fronts. And I would just kind of open it up to everybody to share from your perspective, what are some policy trends that you're seeing? We talked about workforce, but if there are other things, really specific to mental health, early relational health, and how do they fit generally in this larger policy movement that we're seeing to respond? There's clearly people understand there are problems. What are the policy trends that you're seeing now that you hope to see in the next couple of years? And then we can kind of wrap up our conversation. Now, I open it to whoever would like to start.
So I'm happy to hop in here. And so because we do know that babies don't go to the doctor alone, they also don't live alone, they don't grow alone. 0 to 3 policies really reflect the needs of babies, families, but again, the adults that care for them. And so there's 3 main areas that 0 to 3 really focuses on. It's good health, including mental health, strong families, and positive early learning experiences. Those are sort of our 3 main buckets. And within the good health piece, I've heard echoes of all of the policy work that is similar with 0 to 3 and 2, as well as for good health, transforming pediatric settings to support early development more holistically, increasing infant early childhood mental health supports, including trauma-informed care, of course, expanding Medicaid to moms and babies. That feels like a low-hanging fruit one for many states. And then when you're talking about strong families, paid family leave, paid medical leave, and equitable economic base so families can meet basic needs for families or for their babies, but also transforming the child welfare system into a more child well-being system. And really the focus on when you're talking about the most at-risk little ones, I think we can all agree those in the child welfare system are really the main focus that should be. And then the positive early learning experiences, expanding and sustaining an affordable and high quality childcare system, including full funding for early Head Start. And as Cynthia was talking about, early intervention services. And so again, highlighting that these policy priorities are around supporting the adults and systems to recognize and meet the needs of babies all together cohesively.
I would echo everything Megan's saying, and you recognize that the ERA's policy agenda and related to 0 to 3's infant early childhood mental, they're in alignment, absolutely critical. Certainly, the child tax credit right in front of us was demonstrated benefit, then we lost it. It's a top key priority in terms of anti-poverty reduction. That ties directly to anti-racist agendas at every level in terms of really being very intentional in that effort in terms of equity. Paid parental leave, of course, is essential. And then also, that sense of, building out a new envisioned health system that's partnered with communities around preventive mental health. I'm right with Alex. I don't think we're going to treat ourselves out of the mental health epidemic. I think it's a social contract of countering isolation and partnering and connection between public health, informal systems of community, and then a health system, that alignment of that purpose around that vision of connectedness, countering isolation, because that's a force that disrupts maternal isolation, maternal depression by narrative, by support. Back to trying to rebuild that social compact and network of supports that Bruce was talking about has been around forever, that we've lost. And thereby, I think that that agenda likewise is critically important of those levers that could help us in that way.
I just wanted to add to all the things that you said, I completely support. I think that in this space, particularly when we use phrases like infant and early childhood mental health, that sometimes people are thinking about a problem instead of focusing on preventing and building strong you know, emotional and social well-being, building strong mental health. Alex, your work has addressed this specifically, to not wait till there is some sort of issue before you can use medical intervention or social interventions to try and prevent anything. I mean, that's just to say that we are learning that more and more with health. We use the phrase social determinants of health, and that's what we're trying to do with policies to support families, is that we're trying to build a system of support for them so that they are not having diagnosable issues or problems, and that we're focusing on building that health. And too frequently I see in states, when they think of mental health, they're thinking, how do I deal with the mental health problems in front of me, instead of thinking, how do I build the health, both the mental and physical health, but of these families and infants and toddlers. So to just keep that in mind, that this is a continuum. Megan said that earlier, and that we have to think about our policies and programs across that continuum, and promotion and prevention will go a long way, in addition to important interventions and treatments.
Yeah, if I can quickly just, Alex, before you hop in, I think to your point, Cynthia, it's really that stigma around mental health. And I think if there is a silver lining to COVID, I think it's that people are talking about mental health in more positive ways. They're recognizing it. You know, I think people, some folks still have a hard time recognizing or knowing that infants and young children do have mental health. But I'm seeing an upward trend, and I'm really hoping that capitalizing on that someday folks will really recognize health within the infant mental health, or mental health in general aspect of it.
Yeah, I feel like I want to follow you guys around, this panel around, for the next 10 years, and write the CPT code for the stuff you're talking about. Because really financing this stuff is so essential and important. I think, Maggie, your question was, what are the essential policy levers? And not to be too repetitive, but remove diagnosis as a prerequisite for care. You got to go right at that, because that's unfortunately contributing to the pathologizing of poor people. But very quickly on the epidemiology, in the decade before COVID, this nation saw a 104% increase in hospital admissions for self-injury for children. So don't believe the hype. It wasn't COVID that did it. COVID poured a bunch of gasoline on that fire, but we were already having to confront the reality that we had constructed a toxic culture where twice as many of our children were trying to kill themselves. That's not pathology. That's the context in which children are growing up. So we must shift Medicaid's triggering criteria. And the good news is Medicaid already accounts for it. You don't have to have measles, mumps, or rubella to get a vaccine, right? We made a decision in 1967 when we amended the Social Security Act that you don't have to be sick to get stuff as a kid. We just forgot about that when we did mental health. So Medicaid is already written in a way that will help us. So you don't need a state plan amendment. You don't need nothing. EPSDT already allows it. Rewrite the rules. So first. Second, code stuff that actually matters. Like in the dyadic benefit and family therapy benefit, there are actually codes for colicky baby or housing instability. Actually crosswalk reimbursement practice to the things that anybody who works in low-income communities will tell you must be. And then third, we got to look at Medi-Cal managed care, and I've got a fourth too, but because Medi-Cal is being shifted into managed care models, we got to look at subcaps or set-asides. Oregon, Arizona, New York, North Carolina are all, to Cynthia's point and David's point earlier, these concrete supports that families need. Medi-Cal isn't good at paying for it. So what if you carved out a little bit of capitation, created a fund, and paid for it that way? I would call these various forms of subcap arrangements to address the social determinants of health. I think those are really exciting. And the last one I would just say to the feds is, stop one-timing me. Okay? You can't one-time your way out of 400 years of structural inequality. If you're going to do something that changes the landscape ongoing. So an example would be increase FMAP for pediatric mental health visits provided in schools or primary care. I mean, do something that isn't a grant program. And because I'm tired of like getting calls from electeds to take a bow over a one-time thing. Systems don't change with one-time investments. They need the security and surety of ongoing systems change. So go at things that will last would be my last rant. Thank you.
I'll rant about, I'm so with you, Alex, and I'll rant about child tax credit requirements and universal basic income, at least for the perinatal space. You remember Bruce's data about 2-month-olds, the regulatory systems. You talk about child welfare being driven by poverty and the struggle of families who all care about their relational experiences with their babies. But the pressures of daily life without food, housing, security, and safety and connection disrupt those vulnerabilities, and then we punish. And those are really deeply, deeply troubling to me when we know exactly what to do. And we have models of that delivery system. It's time, and it's time to measure, it's time to demonstrate, and it's time to change. Back to the MCOs, there's a counter incentive. You know, how do you demonstrate cost benefit of upstream prevention? Think about decreasing two preemies by doula care supports and the cost savings at the MCO level to the adult decision makers, and put those dollars of savings into prevention promotion. You know, how do we actually move the dial today for a better well-being of new babies, families, with everything that we know? Those are really activist issues that have to happen, I think, at deeply local levels of push and expectation.
Mhm. There's so many threads that I could follow up. I'm personally very glad we got to the MCO issue. I know there are payers in the audience too, and you know, I think you all have a tremendous role to play here in thinking about, you know, using those dollars to get to value, to get to outcome, to like David said, paying for doula care and avoiding the cost of a preemie. I know there's one study that showed $1,000 in savings per Medicaid birth to everybody who had a doula. That is, I mean, you just can't argue with that. And of course, all the other social, emotional, developmental benefits that there are, that we also get cost savings. I can't think of many other interventions where you can say that. I think we are getting close to our time. Here we are, we have 10 minutes left. So I think we had folks who wanted to say some final words. I see Joyce joining us. Joy, do you want to take us out?
I think it's fine if anyone has any final words. Otherwise, we can wrap up just a bit early and give the next session some additional time. So I'll turn it back over to all of you for final words. Anyone want to take us up on that offer?
I'll just quickly say, hopefully the takeaway here is that there are a lot of people doing a lot of different things with a very similar goal. And so that brings me hope when it's very easy to see the doom and gloom and all that still needs to be done. And yet collectively together, I'm really excited to see what this next decade brings and how far we can move together.
I'm with Megan with the hope of possibility. I like to say, as the old pediatrician in me, the birth of a new baby is an opportunity in every family. And there are also healing and developmental forces there that are incredibly powerful if they're supported relationally by others that feel the same way. That's a huge opportunity. So join us for Nurture Connection, our movement at every level of connecting point. Alignment across sectors to this critical message of change is an opportunity in front of us. Thanks.
Yeah, I mean, my final point is just to emphasize what's been said again and again, but we know that there are effective interventions and policies that work. And they will save money, they will promote the behaviors that we want in terms of people working more or attending school more and so forth. But they make a huge difference in the lives of the children and the families, both today and across the life course. And so we have to find the political will to make these investments. We have to pay attention to the details, as folks have said, because merely passing a policy is not enough. We have to get it right and pay attention to equity as we implement our policies. And So I feel that same level of optimism. We know that there are things that work. There are states that are trying all sorts of important things, and we need to be learning what's working well for whom, under what conditions, and replicate that and bring it up to scale so that all families will benefit.
Just like to say to the payers here that we've had the dyadic benefit live since January 1, and it's not hard to convince pediatricians and therapists to do this work in primary care. It's really hard for payers to get their brain around it due to attribution and historical claims processing mechanisms. So I just want to say, like, to the third party folks here or to the managed care plans, like, it's actually a whole different approach, the dyadic benefit, and it takes a bunch of learning. So I just want to invite everyone into like that learning that dyadic care and pediatric primary care isn't a traditional integrated behavioral health practice. It's not refer someone to a therapist down the hall. It means the clinician is working on the team, in the room. And it's a really beautiful, awesome thing I can say as a defunct therapist. I would have loved to have practiced that way. Like it's a great way to do it. So I would really just offer an invitation in my closing words to the third-party payers in the room, managed care plans in particular, to learn the model and see how beautiful and awesome it is. Go visit it. It'll light you up. Thanks.
I'll just say thank you to the panel. This was amazing. And thank you, Joy, for the opportunity for all of us to share together.